This is the AATS expert consensus document for the management of Ebstein anomaly in children and adults. Before I begin, I want to thank all the members of the writing group who really spent a significant amount of time over the course of 2 years putting together 2 manuscripts on the management of Ebstein anomaly. We really needed the buy-in, especially of Jose De Silva and Luciana De Silva and Joe Durrani, as they really represent the majority of the world's experience with the cone procedure, and they were really instrumental in moving this project forward. I also want to thank my co-chair, Igor Konstantinov, who really was very instrumental in putting forth these 2 documents. And also Lindsay Dankmeyer and Jill Kolsch with the AATS, who really helped organize the whole process. When we started the project, in our first meeting, we realized that Ebstein anomaly was such a broad topic that we decided at that point to break it into 2. One looking at neonates and infants with Ebstein, and then the second one, which we're going to present today. The first one was presented by Igor last year at the AATS, and the manuscript is obviously available. The methods are identical to how we have performed these consensus documents for all of the AATS standards. An international writing group was assembled after the topic was selected by the CPSC committee. Ours included 17 people, including 17 surgeons, pediatric cardiologists, adult cardiologists, and a radiologist. Our initial search yielded 455 publications. We performed a systematic review of the literature, and this was based on PICO-formatted questions and included published abstracts of clinical trials from major scientific meetings. After review and discussion, section-specific literature was collated by the committee, and recommendations were created and submitted for a voting process using the Delphi process. The final consensus document underwent external review before submission to the Board of Directors of the AATS for endorsement. The Delphi method, I think, was previously purported by Dr. Jaggers for the PIVS group. Again, this is something that requires an 80% response rate with a minimum of 75% agreement on class and level before this was selected for publication. So to start with the consensus statements, it was divided into 3 sections, and the first section was preoperative assessment. In non-neonatal patients with Ebstein's anomaly, the presence of congestive heart failure, cyanosis, significant left ventricular dysfunction, severe cardiomegaly, and persistent arrhythmias increase the risk for morbidity and mortality. If feasible, we recommend the use of cardiac magnetic resonance imaging for the assessment of both ventricles and the evaluation of tricuspid regurgitation. Asymptomatic older children and adults with Ebstein's anomaly should undergo exercise stress testing with measurement of oxygen consumption to unmask occult exercise intolerance. Cyanosis generally serves as an indirect indicator for compromised right heart dynamics, as it's exacerbated by impaired right ventricular function and severe tricuspid regurgitation. And while right ventricular dysfunction is frequently seen in Ebstein, left ventricular dysfunction has considerably greater influence on patient outcomes. Our second section was surgical recommendations and indications for intervention. Surgery is recommended for symptoms that include fatigue, decreasing objective exercise tolerance, decreased arterial oxygen saturation, and exertional dyspnea. I think that's a classic indication that has carried forth. Cone repair of the tricuspid valve is beneficial when surgery is indicated. The cone repair is a very highly effective surgical technique and provides long-lasting valve durability. It improves biventricular systolic function and promotes reverse ventricular remodeling over the long term. It differs from previous techniques by providing a 360-degree area of leaflet coaptation. The adoption of the cone procedure marks a significant advancement in the surgical treatment of Ebstein anomaly, offering improved early and late outcomes, and in many ways is responsible for the perceived need to develop new guidelines for the treatment of Ebstein anomaly. This is where some of the surgical indications have changed or progressed over time. Now, surgery is recommended when there is severe tricuspid regurgitation, progressive right ventricular dilation dysfunction. Surgery can be beneficial in asymptomatic patients when there is severe tricuspid regurgitation, moderate right ventricular enlargement, and valve anatomy favorable for repair. Surgical intervention at 3 to 5 years of age is reasonable when there is severe tricuspid regurgitation, moderate ventricular enlargement, and a high probability of successful valve repair. With the introduction and development of the cone procedure, these recommendations have changed, and we're now recommending surgical intervention in asymptomatic patients when a high probability of successful repair is anticipated. Performing surgery on younger patients has been shown to enhance the likelihood of successful biventricular remodeling, evidenced by MRI evaluations in the postoperative period. Earlier repair may also reduce the risk of complications arising from progressive right ventricular enlargement and dysfunction, potentially affecting long-term outcomes. Heart failure symptoms, even when severe TR is present, typically only manifest in advanced stages of the disease, and evaluating these signs and symptoms can be challenging unless cyanosis is present. Also, assessment of functional capacity can be difficult in children due to lack of cooperation, and so it was these challenges combined with a previous wide variability in successful valve repair that historically had limited the recommendation for operation in early childhood, which has changed now with the introduction of the cone repair. Bidirectional cavopulmonary shunt is reasonable when there is severe right ventricular dilation, severe right ventricular systolic dysfunction, or failure to separate from cardiopulmonary bypass following repair. Tricuspid valve surgery is not recommended when there is irreversible severe biventricular systolic dysfunction. Transcatheter closure of the atrial septal defect is not recommended when there is severe tricuspid regurgitation or a severe form of Ebstein anomaly. Bidirectional Glenn is not universally applicable to all patients with Ebstein anomaly and right ventricular dysfunction, especially in adult patients or those with impaired LV function. Preoperative catheterization is essential to assess hemodynamics for eligibility. Atrial septal fenestration can also be considered to facilitate early postoperative recovery when RV systolic function is further reduced by the correction of tricuspid regurgitation. And so atrial fenestration does not unload the RV, however, as a Glenn does. Transcatheter closure of ASD may be considered in patients with mild to moderate TR. With severe TR, however, the right atrium and right ventricle progressively dilate. Closure of the ASD does not improve valve regurgitation, and so it can accelerate the progression of right ventricular dilation and subsequent decreased LV performance. I could go into my discussion.
Why don't you see if you can wrap it up?
Sure. Tricuspid valve replacement is reasonable in older adults, that's greater than 60 years of age, and a concomitant maze procedure at the time of surgery is reasonable when there is paroxysmal or continuous atrial fibrillation. Under medical management and perioperative considerations, preoperative arrhythmia evaluation is indicated on all patients with Ebstein anomaly. A preoperative EP study should be performed in all older children and adults with Ebstein anomaly. An intraoperative ablation of arrhythmia substrate is reasonable if the arrhythmia cannot be effectively treated with transcatheter ablation. Risk of arrhythmia increases with age, and we're recommending lifelong follow-up. In patients with evidence of systolic LV dysfunction, it's important to rule out concomitant acquired disease that could be reversible. And systemic anticoagulation may be beneficial after complex valve repair and certainly after bioprosthetic tricuspid valve replacement. So in conclusions, management of Ebstein anomaly requires a tailored and multidisciplinary approach. Introduction of the cone procedure has revolutionized surgical management. Intervention for asymptomatic patients at 3 to 5 years is reasonable if there's a high likelihood for success. Comprehensive preoperative evaluation are critical for optimizing outcomes, and bidirectional Glenn or arrhythmia surgery can offer additional therapeutic benefits in complex cases. The experience is constantly evolving, and we expect to update these consensus documents periodically and treat them as live documents. Currently, a paradigm shift seems to be occurring where cone repair is more frequently considered after a Starnes repair, and in the future, this may be updated in future expert consensus documents. Thank you very much.